years, and so excited to see everybody. I know we have a lot of colleagues virtually, so we'd like to welcome the virtual attendees as well, make sure they feel included, and please, let's make this interactive. Let's learn together, and let's make this a fun event for the next 90 minutes, covering really the spectrum of emerging data from non-muscle invasive bladder cancer through muscle invasive disease to metastatic urothelial carcinoma. So there is a number of learning objectives. I will let you read through that. Obviously, there's so much going on in bladder cancer, and we have a lot of slides today, a lot of content, but we'll try to make it interactive, and hopefully we'll have opportunities for Q&A, again, for an interactive part of learning. Thanks, of course, to the C Concepts, and everybody worked very hard to make this happen, and it's really a pleasure for us to work together with that team. This is me. I'm working at the University of Washington, Fred Hutchinson Cancer Center. I'm serving as the clinical director of the GU group there. I'm a medical oncologist, and I'm really excited and thrilled today to work to amazing individuals, great human beings, and contributors to the GU oncology field. Dr. Samuel Chang, who is, as you see, endowed chair of urologic surgery in Professor of Urology and Oncology and chief surgical officer in Vanderbilt Ingram Cancer Center. And Sam has been doing so much in the field, so we're really excited to work with him today. And of course, another good friend, Dr. Scott Tagawa. He's a professor of medicine and urology in Weill Cornell Medicine in New York Presbyterian, and have had the chance to visit them recently in New York. But actually, Scott that day was out of town. I think it was on purpose. So we're going to have a lot of content. These are disclosures in terms of our research funding as well as consulting. And special thanks, as I mentioned before, to C Concepts. I see Catherine there, Jessica outside, and everybody who worked very hard. And a special thanks to Beacon, and I want to pronounce it correctly, Beacon, the beacon of hope, or beacon of light. Stephanie is over there in the right corner. Well, a big applause for Stephanie and Beacon. So Bladder Cancer Advocacy Network has been a wonderful organization established in 2005 by Diane Quale and John Quale, and has been a really, really forceful, amazing team who has pushed the field forward, has been partnering with us, and with partnering with, of course, colleagues in industry and academia, and has really made a difference in our patients, providing resources, educational, of course, brochures, hotline support groups, research, and so on and so forth. So really, really important to acknowledge what Beacon has been doing. And in that regard, there are opportunities for all of us to be acquainted with what Beacon can provide, print materials, videos, webinars, podcasts for education. Again, they have a clinical trial dashboard where you can find multiple clinical trials for your patients, locations where the trial is open, and of course, treatment matrix and a lot of podcasts discussing opportunities for patients, again, supporting the patient all the way through. And as I mentioned, there's a support line as well. And you can find all of this and more details by scanning. Here's a QR code. So if you scan with your phone, you can go get access to what amazing material and supportive content Beacon has in this institution. So thanks, Stephanie, and everybody in the Beacon team. Now, without further ado, we're going to delve right in, starting from the non-muscle invasive disease. We'll talk about muscle invasive later, and then metastatic disease, focusing on antibody drug conjugate. And it's my distinct pleasure to introduce Dr. Samuel Chang, wonderful professor of urology. Sam, the floor is yours.
Great. Great. Thank you so much, and thanks obviously to our sponsors, and really so much for our patients have really moved the field forward, really with the efforts from Beacon. And I can tell you that the patient-forward materials that are provided, the clinical dashboards, all those types of things, is something definitely you should look into and help distribute, because they're absolutely fantastic. So I was asked to pass on of those in terms of polling of medical oncology versus urology versus others. This will kind of help focus our presentations as we go through, because we have a lot of slides, and so we want to make sure that we emphasize points that we want to emphasize, and we want to perhaps move along in areas that we don't need to emphasize as much. So if we have the results of the audience that we have here, that'll give us an idea. So it looks like we've got more than half the group are the medical oncologists. We have some urologists, and we have others. So thanks to all of you who are here, and this would include also our online colleagues. So thanks so much for participating. We're in an area here where we had a clear dearth of options for our patients with non-muscle invasive bladder cancer, but we've really been able to make a significant change because we have so many more options. So we're going to start off with a case of a healthy gentleman that actually has a history of non-muscle invasive bladder cancer, received BCG at different time periods, but at 9 months, when he had already had several cycles of BCG, he presents with a positive urine cytology and undergoes what's called a CISView TURBT. That's an enhanced way to evaluate the bladder and is found to have actually persistent high-grade disease with carcinoma in situ as well as TA disease. And at this point, this patient we would consider as BCG unresponsive, clearly a higher risk population with those patients that are more likely to progress, more likely to have issues, and clearly now we had not had a lot of opportunities in terms of therapy options. So one of the things that we thought about were different ways that we can treat these patients to salvage treat them after BCG unresponsive disease. And so these are options that I think you all should all put in. There's no right or wrong answer. Perhaps there is a wrong answer. Remember, this patient had BCG, more BCG, and still had CIS and high-grade TA disease. So whoever chooses reinduction BCG, it's probably the urologist because we're not the smartest in the room. Remember that it's something actually that probably is unlikely to work. Other options would be other chemotherapy agents, intravesical chemotherapy other than gemcitabine and docetaxel. We'll talk about that. Systemic therapies such as pembrolizumab, nadofaragene, which we'll discuss, cystectomy and clinical trial. So if we have the results of that poll, that will give us an idea. And so we have a majority, and this distribution I think really makes sense because there's no set standard therapy at this point yet. And there are options, and we'll talk about all these options as we go through this. When you look at non-muscle invasive bladder cancer, you know, we want to be aggressive for those tumors that we need to be aggressive, but we also want to de-escalate those treatment parameters for patients that have less aggressive disease. And so risk stratification, just like evaluation of treatment success, I think is increasingly important. So it starts off with performing a good TURBT, and that includes actually getting deep specimens, sending pathologic specimens that are helpful for our pathologists, understanding the importance of repeat TURBT. These are techniques that urologists are well aware of, but do we do this every single time? Oftentimes we don't. And we need to understand that enhanced cystoscopy can help us find lesions that we otherwise would not be able to find, because we need to help pathologists as much as possible. I mean, it's too often that we send actually specimens like this to our pathologists where they have to orient specimens, where they have to try to figure out, has this patient got muscle invasive disease in all those different specimens? So whatever we can do to improve our quality of TURBT, I think that'll be very important. Risk stratification continues to be something that evolves. We're so much better now compared to what we used to be, but we're learning that we've got many more steps to take to help determine what we need to do. So one of the things that we've done with guidelines, and this is the AUA SUO guidelines, is attempt to risk stratify. And by doing this is a busy algorithm that you can see up front, but what it takes into account is that there's a risk stratification schema for low risk, intermediate risk, and high risk that actually is iterative. And so when you look at this and you divide these patients up, they clearly meet certain criteria, but they also then are predictive of who recurs and who's likely to progress. So importantly, by understanding that, we can either escalate treatment when we need to or de-escalate it when we don't. And so there are lots of guidelines, lots of different methodologies, lots of different ways that we present what's out there. But clearly the importance of understanding who's at higher risk versus those that are lower risk are important. And so I think the EAU has done a nice job in terms of, again, breaking them out, very similar to our guidelines in terms of the AUA, but also teasing out certain risk factors that put patients at higher risk disease. And I think that's important. So when understanding that, let's look at how we risk stratify and what we do in terms of treatment. And first, we need to use BCG appropriately.
BCG, for the medical oncologist, I think you all understand, it is our standard treatment. It is our treatment of choice. It is a treatment that we use for decades for high-risk disease. And understanding that BCG is effective for the majority of patients is important. But then we have issues and changes. There's been a significant BCG shortage, one in which there's been a somewhat random distribution scheme of who gets BCG, who doesn't. There are patients in the same city who see different physicians, where physicians within a few blocks cannot get BCG versus those who can. We actually queried Merck. We hadn't heard anything publicly for more than a year and a half when we actually approached Merck and asked them these questions. And they're making attempts to improve and increase production with a new facility and that type of thing, but we're still hundreds of thousands short of vials in terms of what's needed. And so we need to do a good job of risk stratification and understanding that. Part of that is utilizing actually intravesical therapies other than BCG and understanding that they can be effective. So for the urologist in the audience, one of the key kind of innovations that's been reported at this meeting, actually several years at different time points, is the combination intravesical chemotherapy of gemcitabine that our medical oncologists are well aware of, understanding the effectiveness of that systemically, but combining it with docetaxel and actually placing it in the bladder. And in terms of effectiveness, seems to be a very effective regimen for those patients who are either BCG naive or BCG unresponsive. More recently, this is work out of Columbia looking at triplet therapy. So oncologists are converting, here we've got monotherapy, we've got doublet therapy, and this is actually a triplet therapy adding cabazitaxel to the combination of gemcitabine and platinum. So again, attempts to do things intravesically to treat those patients with BCG unresponsive disease. And if you look at 2-year response-free rates in terms of being disease-free, at 24 months, 64%. These were in BCG unresponsive disease. So understanding that there are treatment alternatives, none of these are yet FDA approved, but they are now being used more commonly. An important breakthrough that you all should be familiar with is the FDA approval. Actually, this was in December of 2022, just a couple months ago, looking at the first gene therapy, and this is natafaragene, looking specifically at those patients for BCG unresponsive disease, and it has been FDA approved. And so this was based upon looking at an agent, natafaragene, which is actually a replication-deficient adenovirus that utilizes and augments interferon alpha. So interferon alpha has been put in the bladder in the past, showed some minimal effectiveness, but this is actually an augmented attempt to magnify the impact of this. And this is actually a treatment given once every 3 months, and the response rates were actually quite significant. If you look at for CIS as well as for Ta/T1 tumors, by 3 months, you had a response rate of more than half actually were disease-free. And a significant percentage of those patients were able to maintain that at the 1-year mark. So here's their durability. These are for patients with CIS, vis-a-vis those patients with high-grade Ta/T1 disease. And you can see that over time there is some loss of efficacy, but there is a cohort, just as we see with other types of immunotherapy, that have persistent, durable, long-term responses. So this has been FDA approved as an intravesical therapy for BCG unresponsive disease, but we do not have it yet commercially available. There are thoughts that it may be at least several months, if not longer, before it becomes actually clinically available. So we've talked about for risk stratification using BCG carefully and appropriately, understanding other intravesical options, but from a urologic surgery standpoint, we need to understand that cystectomy still plays an important role, and understanding that delay of cystectomy ultimately can be harmful for these patients. And so there are certain terms and topics that we've talked about in terms of, hey, some of these patients may need to go straight to cystectomy. And that would include certain characteristics. And the reason and rationale behind that is we know that radical cystectomy, for the vast majority of these patients, is curative. And we understand that the 5-year survival rate is quite high. The problem is is that there is significant morbidity associated with cystectomy. And when we look at that, we understand that, okay, a significant percentage of patients can recur and can progress if we don't take out their bladders, but we weigh that against their morbidity of performing the cystectomy. The complication rate of cystectomy at Vanderbilt is 40%. So when you tell that to patients and understanding the possible quality of life issues, we really need to kind of balance out who gets a timely cystectomy and who doesn't. And this is a slide that I've shown for a long time. I'm not a complicated person. I like simplicity. I like an idea of what's important and what's not. And there are certain things that really drive us to do an early cystectomy. And timely cystectomy is actually a term that was introduced by Dr. Michael Cookson, who's in the audience. I don't want to embarrass him, but he's sitting there right over there. He actually introduced the term in the Gold Journal more than 2 decades ago, understanding that there are certain characteristics, high-grade T1 disease, looking at lymphovascular invasion, the depth of involvement, CIS. There's certain characteristics that would drive you to moving to a timely cystectomy. And understanding when you can't perform a TURBT successfully or safely, another indication to move ahead. And clearly variant histologies where we have not shown really any effective intravesical therapy, we need to consider it. So, systemic therapies. I think the medical oncologists are well aware of the use of systemic immunotherapy, and specifically systemic pembrolizumab has been studied in this non-muscle invasive bladder cancer group that is BCG unresponsive. And if you look at kind of the response, again, there is a signal at the 3-month mark of around 40% that have a disease-free state, and a percentage of those, again, at 1 year are able to maintain that. And if you look at kind of the plots of who succeeds and who doesn't, it's the minority of patients that respond, but those that do respond tend to have a long-term response. So as a result, we have an FDA-approved intravesical therapy, but we also have an FDA-approved systemic therapy, and that's pembrolizumab. Importantly, our clinical trials, we need to continue to do that, and we're quite fortunate in that this space has exploded. One of the trials more recently that's been published, and actually in New England Journal Evidence has been published, but also is going to be actually discussed again in abstract form by Dr. Chang in UCLA later on tomorrow, is again the impact of certain combinations. So this is a combination of N803 plus BCG. N803 is an IL-15 actually super agonist that hopefully augments the response. And if you look at kind of comparisons, and this is unfair because we have different patient populations, but clearly there seems to be a robust long-term response with this combination agent. So what's next? I think all the trials are looking at therapies at a sooner date, combination therapies, understanding the role of augmenting and supplementing actually these combination therapies. And this is for BCG exposed patients as well as for BCG naive. I think if you look at current salvage therapies for BCG unresponsive disease, we've got FDA-approved agents now, which we really hadn't had in the past that were successful. So we have natafaragene in the intravesical space, we have pembrolizumab in the systemic space, and then we have promising trials that are ongoing. So one of these promising trials is something that Dr. Grivas wanted to emphasize, and I think it's very important, is, we've got some data looking at chemotherapy within the intravesical group. And so there's a cooperative group trial looking at actually the gemcitabine docetaxel that I mentioned, but actually going head-to-head and actually doing that in a patient population that was BCG naive. So understanding that more BCG isn't necessarily effective when we have these options, let's go to this question here. Which is a patient with CIS that receives BCG, gets BCG maintenance, and is then seen and has persistent disease. Excellent performance status, but says, you know what, I don't want to have a cystectomy done. I want to have another option. So this is a bit tricky because it's a not question. So if you look at these, which would be reasonable to receive. We just talked about the study trial of gemcitabine and docetaxel, and we've shown the data regarding that. We talked about the FDA approval of IV pembrolizumab as well as for nadofaragene. And then we just talked about reinduction BCG may not be helpful, but I don't want to give away the answer. So you guys plug that in, and we'll save the results, or should we show that? I'm not sure if we want to go ahead and show that, because I don't want to embarrass the urologist who put the wrong answer down. So if we have the results back yet. So this is an attempt to see if we've shown any differences in terms of pre and post. And afterwards, there were more people who have looked at pembrolizumab as well as nadofaragene in terms of treatment, and then understanding, though, correctly that the wrong answer is giving more BCG. So in this patient who's already received BCG, to give more really doesn't make sense. So in terms of conclusions, BCG really is the treatment of choice. It's a study point comparison. Importantly, though, we're starting to look at trials that are going against BCG, actually comparing to see if they can be used as first line. Understanding that we have FDA-approved agents, nadofaragene as well as pembrolizumab, and understanding that clinical trials continue to be important. We have exciting data. We're waiting for FDA approval for other agents. I think on the horizon, at this time next year, I would not be surprised, and I actually would expect that there are going to be other agents that are FDA approved that are going to be equally effective, if not more so than the currently available agents. How we sequence them is a question that I'm sure Dr. Grivas is going to want to ask, and right now we don't know. But it's an exciting time, and thank you for your attention.
Sam, this was a fantastic presentation in a very rich content in a very efficient amount of time.
You know, Petros, I just look at you, and you're the model of being able to present a lot of data in a short period of time. So I take that as a huge compliment from you.
Great job. And actually, I have one quick question for you already, and then we can talk about the sequence of therapies as you brought it up. So one of our colleagues in the audience is asking, when this new gene therapy becomes commercially available, nadofaragene, Therapeutic,
sure.
How do you anticipate that will change your current standard of care?
Yeah, I think that from a urologic standpoint, there has been, I wouldn't use the word reluctance, but there's not been a huge kind of uptake of using systemic immunotherapy for those patients that have non-muscle invasive disease, even though BCG unresponsive, even though with a risk of progression. So to have an FDA-approved alternative that is an intravesical treatment that is given once every 3 months, basically once a quarter, could be a significant improvement, and I think there'll be uptake. The issue is there's going to be a learning curve on how to give this. This is gene therapy. There's certain requirements of how to use this safely, how to store it, what to do, and so there's going to be a learning curve required with that. But to have a true alternative, I think, is exciting.
I think it's very exciting to have options for our patients, and
absolutely.
You said it perfectly, Sam. I agree with you.
Absolutely.
So, Scott, what do you think here? We're going to have options like systemic intravenous pembrolizumab. Sam just talked about nadofaragene firadenovec intravesical. Intravesical chemotherapy is still something you're using, right?
Oh, absolutely, absolutely. And I think a question that I can throw back to you all is, how often do you see the non-muscle invasive bladder cancer group of 100 of your bladder cancer patients, what's the percentage of non-muscle invasive bladder cancer that you see to give immunotherapy to?
So in the real world, I think in private practice, I think it's very low. At an academic center where a lot of the trials are multidisciplinary, where we might be giving only systemic therapy or a combination of systemic therapy and intravesical, we see them more frequently. A lot of these that lead to accelerated approval are called phase 3 trials, non-randomized. So I think it's reasonable, separate studies that really can't be compared. They're in the urologist's hands. I think it's fine to give intravesical therapy.
Yeah.
I don't know that it's better or worse, but I think it's fine. I also, as you mentioned, combinations that make sense. These are the basic principles of oncology, non-cost-resistant combinations.
Absolutely, I agree.
And interesting question, Sam, and I can share with you in the University of Washington, we have this multidisciplinary bladder cancer clinic mostly for muscle-invasive disease.
Sure.
But more recently, we see a little bit more of BCG responsive NMIBC, those patients, and we have a discussion about clinical trial, if available, intravesical chemotherapy, nadofaragene may be available soon, or systemic pembrolizumab. It's a good discussion with the patient to hear all the approaches. But I would say the uptake of intravenous pembro has been lower than expected.
Sure.
At least in my practice.
No, and I agree. And I think, that it will be with ongoing trials. The question is, how much augmentation the systemic immunotherapy will add to some other type of intravesical component. So I look forward to the trials. I look forward to seeing the results. But your question regarding how you're going to sequence them, nobody knows. And you had pointed out similarly how the medical oncologists have also thought about, okay, post-chemotherapy, how do you line things up? What do you do? What do you consider? And I think the characteristics that you brought out in terms of patient characteristics, disease characteristics, bladder capacity characteristics. So for us, in those patients, people ask me, who do you refer for systemic immunotherapy? Some patients have had so many intravesical therapies that their bladders have significant problems with volume and contractility and compliance, and they still don't want their bladders removed. It's difficult to justify another intravesical treatment. And so for those patients, I definitely lean towards attempting a systemic therapy. So there's a lot to balance out in terms of where you're going to go next and what do you do. And I think as treating physicians, you're going to be balancing all of those things.
Absolutely. And I think you guessed perfectly the next question, which is realistically, pragmatically, how many lines of therapy can we sequence in BCG responsive NMIBC?
Yeah, I think that's going to be a real question. I think I don't go to Vegas often. I really think there's going to be one or two winners, and those are going to supersede the others. So they're going to be more, fortunately, FDA-approved agents that are going to be, I think, much less commonly used. So which of those are going to actually win out? I don't know. It could be a treatment schedule. It could be difficulty with handling the treatment of what you do with it. Where do you store it? How do you give it? To me, it's unclear what's going to win. Is it going to be efficacy data totally, or is it going to be safety data and tolerability? I don't know. I think it's going to be a combination of all those things. And the issue is, and this is good, is that every treatment has actually different success and efficacy and different side effect profile, different delivery schedules, different delivery options. And so how you balance that is going to be patient-physician dependent, I think.
100%. And you covered all these factors, right, we take into account. Maybe last question, Sam, for you.
Sure.
The FDA is looking at the data with the N803 plus BCG. Any thoughts you have how this will play out, or?
I haven't presented to the FDA regarding this. I think that, and I'm an investigator for N803, so everybody needs to know that. I think that the data, and you can't compare, to compare that unfair slide that was shown. It's an unfair slide because it's not direct apples to apples, but the safety and the efficacy data is very persuasive. So if there's no issues, I think with safety and production and manufacturing, I think it'll be approved and approved quickly, just because it clearly does have significant efficacy, great safety tolerability profile, and it's yet another alternative in patients who really still don't have a lot of alternatives.
Absolutely, and I'm sure Stephanie is smiling because we have many more options for the patient.
Oh, much so.
Absolutely.
Great. Oh, thanks so much. Yep.
Fantastic. What a wonderful presentation and great discussion. I think we're on time, and I'm going to jump right into the muscle-invasive disease. I hope everybody is doing well. Again, people in the audience here and on virtually, please chime in, ask questions. Let's make this interactive. So I'm going to travel relatively fast here because there's so much data to cover. But I want to point out that the bladder cancer is a very common cancer, the fourth most common cancer in men, and the sixth most common if you have both genders. And I think it's the most expensive cancer to treat. on a per patient basis, from diagnosis to death. So very, very important for, and I talked to our industry colleagues there to keep investing to find more treatments for our patients. And obviously we have to improve the cure rates, we have to improve overall survival, progression-free survival, and of course, have patients have a better quality of life. I just mentioned a minute ago, I had the opportunity to discuss the multidisciplinary bladder cancer clinic that we have at the University of Washington. And I put that here. It's a wonderful clinic that was set up by my colleagues before I went to back to the University of Washington. I was in Cleveland Clinic at the time, by Dr. Montgomery, Dr. Wright, and others at UW. And this is a one-stop shop for our patients. And this is when the patients come in on Tuesday morning, for patients at its week. And they see urologic oncology, medical oncology, and radiation oncology, pathologists and radiologists. And these patients are being evaluated. We have images review, pathology review by GU pathology experts, radiologists that are specializing in bladder cancer. We published a manuscript that about 6% of the patients, we actually have a change in the plan based on this expert review. So I think it's a patient-centered approach. It takes a lot of resources, and of course, we're partnering with great colleagues, in other centers. I see Dr. Zhao in the group there. We share patients, and it's wonderful to have this dialogue and communication with colleagues from other cancer centers. So I think that slide just talks about the importance of the multidisciplinary approach in bladder cancer management that we have at the University of Washington and Fred Hutchinson Cancer Center. The slide that I'm showing you here is really a 1,000-foot view of the different therapy settings, and Dr. Chang did a fantastic job covering the non-muscle invasive disease. I'll spend some time for the localized curative intent muscle invasive bladder cancer, and then we'll talk about metastatic disease. So there's no doubt in my mind that neoadjuvant cisplatin-based chemotherapy, either with dose-dense MVAC or gemcitabine cisplatin, either or, has a standard role before radical cystectomy, lymph node dissection, and neoadjuvant cisplatin-based chemotherapy prolongs overall survival. It's often better tolerated compared to giving it adjuvantly after surgery, and obviously we want to maximize the impact on outcomes, and we have phase 3 trials showing this overall survival benefit with neoadjuvant cisplatin-based chemo, and at the same time, we try to achieve pathological complete response for our patients, which is a surrogate for great outcomes in the context of neoadjuvant chemotherapy. It can help us get some information about the tumor biology. As I mentioned before, the SWOG 8710 trial in US and the EORTC trial in Europe showed significant overall survival benefit with cisplatin-based combination chemotherapy with what I think is both clinically significant and statistically significant improvement in overall survival. I think the important point is we do not use carboplatin in the neoadjuvant or adjuvant setting in bladder cancer. If someone cannot get cisplatin based on Galsky criteria or let's say a derivation of that, either can go right up front to surgery or to clinical trials, so we have plenty of those, or of course to bladder preservation for well-selected patients. Now, there is a lot of discussion, and we discuss with colleagues about the dilemma dose-dense MVAC with growth factor support or GEM-CIS. I would say briefly, there's no huge difference demonstrated in clinical trials. There was this phase 3 VESPER trial that was presented last year by Dr. Feister, I think it was ESMO, and Dr. Grante was a presenter. That trial tried to compare the two regimens. There were some methodological questions. For example, they allowed neoadjuvant or adjuvant therapy, and also the number of cycles. They had 6 cycles of dose-dense MVAC and 4 cycles of GEM-CIS. Bottom line, there was suggestion that there is a trend towards disease-free survival benefit with a dose-dense MVAC, and you see there a very small numerical difference in pathological complete response rate. If you ask me, my bias is in fit patients where I feel comfortable with, I favor dose-dense MVAC in patients who I think can tolerate it. But there is significant variability, and I'm very comfortable when someone gets GEM-CIS. Scott, any comments on your preferred neoadjuvant regimen outside of a clinical trial?
Yeah, dose-dense MVAC. So Cora Sternberg, who is credited with this regimen, actually helped develop MVAC as well. Even before she came to our institution, that would be my preferred regimen. But not everyone is going to be able to tolerate it. So cisplatin, I think, is the key, cisplatin combinations.
Some any Vanderbilt kind of approach?
I think very much to Scott's kind of comments, our preference is dose-dense MVAC.
you know, and honestly, it's investigator dependent as well. So I would say the preference has been dose density, and the rationale behind that is at least from a trial standpoint, this shows some equivalence, and the equivalence data is for metastatic disease. It really hasn't been large, studies in terms of neoadjuvant, so we tend to lean to dose dense, in fact.
And just for the audience, the way dose dense and vac is given is one drug after the other, all on one day, at least how we give it, and then growth factor support every 2 weeks. Scott, do you give it the same way?
So I'd say, not to really correct you, but to clarify, so there's accelerated MVAC, which can be done all in one day, and there's dose dense, which is the traditional methotrexate in day one. And then the other drugs on day two, there's trade-offs in terms of convenience, but one advantage one advantage of the 2-day regimen that I sometimes find useful is that I can give them hydration on day one and day two.
And just for the clarification, great point by Scott, accelerate and vac is what I described with all drugs on day one, and the dose dense is if you give day one and day two. And it's kind of variation among different centers, how they do it, and of course where the patient lives, right? If it's close by versus far away from the cancer center. But either way, I think it's very reasonable. And in either scenario, you give growth factor support, right? Okay. And we do 4 cycles for node-negative disease. That's what you do. Okay. Consistency here. So again, there is some data in this particular slide looking at the different toxicities, maybe some trend towards a little bit more fatigue, nausea, vomiting, and anemia with dose dense and vac. And again, there's a trade-off to some degree. That's why I think patient selection is very important, like everything we do in medicine and oncology. Now, we discussed cisplatin-based chemotherapy. There is definitely effort and many attempts to build upon the backbone of cisplatin-based chemotherapy and try to see whether the addition of immunotherapy with checkpoint inhibitors adds value or not, right, in the dose dense and vac or GEM-CIS. And I see in that particular slide different trials, 5 trials that looked upon the question of chemotherapy plus checkpoint inhibitor in single-arm phase 2 designs. And the take-home point is that the pathological complete response rate looked promising, but of course we need phase 3 trials to see whether the addition of checkpoint inhibition adds survival benefit, event-free survival or overall survival benefit. And at least for now, I'm not using checkpoint inhibitor outside clinical trials in the neoadjuvant setting. Would you agree with that statement, both of you? Sounds great. So definitely we're excited about clinical trials, and this enthusiasm comes because the phase 2 trials look very promising. In that particular slide, the question is, can checkpoint inhibition in the neoadjuvant setting have a role? And you see data from the Pembro Pure 01 trial by Andrea Necchi in Italy and the atezolizumab by Abacus trial by Tom Pauls in UK, and you see that the pathological complete response rate look pretty compelling. Again, we have to validate these results in phase 3 trials, are not ready for prime time. And of course, there is a series of other trials. In this particular slide, you see trials with single agent or combination immunotherapy. All of them, again, phase 2 trials look very promising, but we have to wait for phase 3 ongoing trials looking at different combinations or single agents of immunotherapy agents in neoadjuvant setting, and those trials have to read out. And maybe in a few years from now, we may have more data about neoadjuvant checkpoint inhibitor, but for now, the neoadjuvant checkpoint inhibitor is experimental in clinical trials. What about adjuvant therapy? And before I go to adjuvant therapy, I think we're going to ask the question here to the audience. And the question is, how often do you check PD-L1 expression in patients with metastatic disease? So we're going to talk metastatic disease in a second, but just a preemptive question. When you see a patient with metastatic urothelial cancer, bladder or upper tract or urethra, how often do you check PD-L1 expression in that patient? Does it make a difference in your practice? I was promised some Greek music, but I don't hear Greek music, but that's okay.
Oh, you get music. I didn't get music.
Okay, so there's a variety of different answers here. I like it, thank you. So some people never, about 30%, and some others, they check it. Scott, what do you think? What do you do?
So some of the times I get it without asking, honestly, because across the board, some of our pathologists just do what they think is lung cancer or whatever else. And in the past, we did ask for it more, and I also, might use it for retrospective research there or not. But generally, in terms of me asking for that to make a difference in terms of what I'm going to do, not useful.
Not useful. Sam, any comments from there?
I don't, our medical oncologists, I don't think they often, I think early on when FDA indications type tended to kind of influence those decisions, now it's very uncommon that they do it. But it's funny what Scott said. Some of our pathologists will automatically run the IHC or whatever test, and then and do our medical oncologists put any weight on that? No, they don't. So
I'm with you. I'm not checking at all PD-L1 expression, and we'll go through the data in a second, but I wanted to see what the colleagues in the audience think. So let's see here. That's another question that I'm seeing, and the question is, I think we just talked about it, right? Yeah. So the big question that happens often in the clinic is I see a patient who comes to me after radical cystectomy. Obviously, patients who are seen by our urologists, they are being sent to us before for discussion about neoadjuvant chemo. But what happens if you see a patient in the clinic who already has undergone radical cystectomy, lymph node dissection, and comes to discuss adjuvant chemo, and this patient has never received neoadjuvant chemotherapy naive. And without this editorial, a lot of time has passed, 6-7 years ago now, with some good friends you see in this slide. And the take-home point, at least in my practice, is if I see a patient who is fit for cisplatin, not carbo, but cisplatin, and they have never got neoadjuvant chemo, and they have T3 or T4 or node-positive disease, I'm offering this patient cisplatin-based chemotherapy adjuvantly. If a patient has already received neoadjuvant chemo, there's no good evidence to give more. It's already given neoadjuvantly. Scott, any comments on this?
Agree. I mean, so, hopefully this is in cisplatin unfit, or, occasionally for non-muscle invasive disease, you do cystectomy and it's node positive or something like that.
Yep. Any comments, Sam, from you?
no, to be honest, we had not historically referred patients for either neoadjuvant or adjuvant. 15 years ago, we really didn't. We didn't have a lot of options. We didn't think that there was really anything effective. I think now perioperative use, either neoadjuvant or in the adjuvant setting, I would say 95% of our patients with invasive cancer see our medical oncologist pre-op and post-op.
Excellent. Thanks, Sam. Great points. So there has been an important trial by Dr. Biddle in the UK and the team there called the POW trial. This is after nephroureterectomy in upper tract urothelial cancer, fully resected with no evidence of disease. And the question is whether adjuvant chemotherapy should be given in those patients. As you see, this was adjuvant gemcitabine cisplatin in most patients and showed disease-free survival and metastasis-free survival benefits with adjuvant gemcis versus observation. So this trial was practice changing, and this was for pathologic T2 or higher T stage or node-positive disease with upper tract urothelial carcinoma. In my practice, I offer those patients adjuvant chemo if they had never given, they were never given neoadjuvant chemo before. The big question remains for the cisplatin ineligible patients, and there was a small subset in that trial. Carbo-gem was given in 96 patients. It's a big debate whether carbo-gem should be considered or not in the adjuvant setting, based on this small sample size with large confidence interval. Scott, what are your thoughts on that?
So, it depends. So, just talking about preoperative, we don't have the same level of evidence, but because I know, not that I know 100%, but almost everyone is going to have a decrease in renal function with one kidney, I will generally give neoadjuvant when I can, when they have two kidneys that are there without level 1 evidence, extrapolation. Someone has, let's say, again, node positivity or something like that, based on, so we're not there yet, but in terms of adjuvant PD-1, there's some data that the upper tracts are maybe going to be FGFR3 driven, maybe less responsive to immunotherapy. So, that would be the situation where I might consider adjuvant Gem-Carbo. So it's a small subset in a perioperative setting where I would consider carbo. That might be at one time.
Very, very few selected patients with really high-risk disease, and you cannot give cisplatin, you're worried about it. Sam, any comments?
We definitely tend to push neoadjuvant. And just like Scott was saying, I mean, we've gotten some evidence, Jonathan Coleman's group and the folks there at Memorial recently published in JCO looking at their combination, and they risk stratified not necessarily by stage actually, but by high-grade disease. So it's basically high-grade disease, clinically invasive, but the only real criteria was that they had to have high-grade disease, and they had pathologic response and some pathologic CRs as well. But their endpoint was actually pathologic response and not necessarily actually disease outcomes. But similar to neoadjuvant chemotherapy for the bladder, if you're successful and you're able to get a pathologic response, and it was a pathologic complete response, the disease progression curves as well as cancer-specific survival curves were much different, were much beneficial in terms of being able to gain some benefit. Our oncologists do give Gem-Carbo post if they haven't received it neoadjuvant, if they have high-risk disease. We don't push them hard when they do that, but they'll be also the first to say this may not be as effective, but I'd rather do this. So.
And that illustrates the need for clinical trials in that space. And I just want to give a shout out to the ECOG-ACRIN 8192 trial. This is a trial that we're running with Dr. Ginny Hoffman-Sensitz. It's a neoadjuvant trial for upper tract urothelial cancer. And we do dose-dense and VAC with or without durvalumab, a phase 3 trial to follow up on the data that you quoted, Sam. There's some phase 2 trial data with chemotherapy in upper tract. And also we have a cisplatin-ineligible cohort, durvalumab gemcitabine. So if you guys have opportunity to open that trial, it's great. ECOG-ACRIN 8192. It's a cooperative group trial looking for neoadjuvant chemotherapy, immunotherapy combination. Now, what about adjuvant checkpoint inhibitors? We have 3 important purely adjuvant immunotherapy trials. IMvigor010, this was a trial asking the question of atezolizumab or observation as adjuvant therapy for patients with resected urothelial carcinoma, upper tract or bladder, and patients who were allowed to receive neoadjuvant chemo, but it was also not mandatory. So patients may or not have received neoadjuvant chemo. This was a negative trial, no significant disease-free survival benefit and no OS benefit with adjuvant atezolizumab observation in the IMvigor010. So this did not change practice. Obviously, when you lose a game in basketball, you want to learn why you lost the game, right? And I love basketball, and I also love research. And that's actually a study we published with Tom Powles and colleagues in Nature, looking at the ctDNA as a putative prognostic biomarker. And the question here is, if you have positive ctDNA, detectable ctDNA, after surgery, you have a much higher chance of recurrence or death. It's a negative prognostic biomarker. You see that in the observation arm. The big question is it whether it is or not a predictive biomarker of benefit to atezolizumab. The paper we published in Nature showed that potentially yes, if you have ctDNA positive, you may benefit from adjuvant atezo. When you ctDNA negative, you do not. Obviously, this is an exploratory endpoint of the trial. This did not change practice, but definitely raises enthusiasm and set the stage for the next trial in IMvigor011. In that trial, only ctDNA positive patients then will be randomized to atezo or placebo. Those with ctDNA negative will not be on the trial. So that will evaluate the clinical utility of ctDNA. Similar trial, but our friends in Denmark, Dr. Diskrot and colleagues are doing a trial similar, adjuvant setting, detectable DNA in the plasma, atezo, negative surveillance. That will show whether this adds value there. And we're waiting to see those trials. And the next trial by Dr. Galsky in Alliance, very interesting design, ctDNA positive patients, nivolumab, adjuvantly plus minus relatlimab and LAG3 inhibitor, and ctDNA negative patients, nivo or surveillance, and with nivo at progression. And that trial, I think, is going to answer this question about the clinical utility of ctDNA in the adjuvant setting. Now, I mentioned the adjuvant atezo trial, but what about the adjuvant nivo trial? This was a positive trial, very similar design, CheckMate 274, phase 3 trial, resected urothelial carcinoma, upper tract or bladder. Patients may or not have received neoadjuvant chemo, got nivolumab or placebo in the adjuvant setting, and they were stratified, as you see in the right part of the slide. And that trial met the primary endpoint of disease-free survival benefit, hazard ratio 0.70, and the hazard ratio was even lower in patients with PD-L1 high or positive tumors. And that trial resulted in the FDA approval of nivolumab in patients with high-risk disease who meet the inclusion criteria of that particular trial. And the interesting thing is that the FDA approved it in all comers, regardless of PD-L1 expression. In Europe, the EMA approved it only in PD-L1 high patients. So some interesting discrepancy how the regulatory agencies read this data. And of course, we have the tiebreaker ambassador trial. And this is trial looking at pembrolizumab versus observation in the adjuvant setting. I think that trial is going to report in the next year or two. Dr. Apollo from the NCI is running this trial, and we're interested to see whether this will be the tiebreaker between a negative and a positive trial. So very quickly, take-home messages. Clinical trials are my favorite 2 words. It's what I think in the morning when I wake up. And, of course, cisplatin-based chemotherapy is the best we have, ideally neoadjuvantly, as we mentioned before. Adjuvant nivo has FDA approval in all comers regardless of PD-L1 expression in patients after a radical surgery with or without neoadjuvant chemotherapy. It's an option to discuss with the patients. We have not seen overall survival data yet. From the CheckMate 274 trial, we're waiting. Ambassador, adjuvant pembro observation, is close to accrual. The Proof 302 trial, that was an adjuvant FGFR inhibitor in selected patients based on the biomarker versus placebo, actually was terminated. We're actually looking to see in this contemporaneous cohort what is the incidence of FGFR3 mutations and fusions. So that's something we're going to look at and present in the future meeting. And of course, circulating tumor DNA has emerging very interesting data, but in my opinion, remains experimental. And the question to you guys is, are you using ctDNA in the adjuvant setting to make a decision? Scott, we'll start with you.
No, not outside of a clinical trial.
Sam, the same
Not
thing.
yet, no.
We think alike, the 3 of us. So to me, we have to wait for these phase 3 trials to establish clinical utility. And variant histologies, I did not mention much about it, but there's a huge interest we have, and hopefully more trials in the variant histology setting. As you see, I'm trying to pace myself quicker because there's so much data. But for bladder preservation, I want to make the point that it's a very important consideration in well-selected patients. About 10 to 20% of patients in our practice are ideal candidates for bladder preservation. The backbone of that is maximum TURBT, followed by concurrent chemotherapy and radiation. And we have actually a couple of clinical trials looking at the addition of checkpoint inhibitors in that chemoradiation backbone. So the SWOG 1806 is maximum TURBT, followed by concurrent chemoradiation, and there are 3 chemotherapies allowed, one of the 3 is given, plus minus atezolizumab. So the question is, atezo, does it add value to chemoradiation? Very important trial. It's about 3/4 accrued, so more to come. So very quickly, the question, maybe Sama will ask you first. Maybe you can ask me a question, actually, because you have the iPad.
Yeah,
We'll
because you always, we learn, I've got gray hair, so I've learned the best way to answer a question is to ask a question. So this is a virtual question. If the second line of treatments, combination of chemo discussed earlier on, fails, is there any third line of therapy to use?
Is that for metastatic disease?
It's unclear from the question, but let's say for metastatic disease. So let's save that question. Oh, this is, I think, a classic one that people are asked. And I think there's certain rationale behind this. How do you explain the negative atezolizumab adjuvant trial versus the positive nivolumab adjuvant trial?
That's a very long answer. I'll try to be concise, which is not easy, but I'm from Athens and we give long answers. The Spartans are more laconic. So I'll try to be laconic, but I think there are many differences. Number one, PD-1 versus PD-L1 inhibition. Does it matter? We do not know. This is a very hand-waving answer because nobody has really compared the two in bladder cancer. So I do not think it's the answer to our question, but some people underline the difference between the two trials, PD-1 versus PD-1 inhibitor. But I think more importantly, in my opinion, is that the performance of the control group was very different in the two trials. Okay. In the adjuvant atezolizumab observation was the control and performed pretty well. The median disease-free survival was, I think, 16.6 months, while the performance, the median DFS of placebo on the adjuvant nivo was only 10.9 months. So about 6 months difference in DFS in the performance of the control group. I'm not saying that's the only answer, but it's definitely relevant because it can affect the delta. So I think the performance of the control group may have played a role. I don't know if you have any thoughts, Sam.
So you don't think there is an innate difference between PD-1 versus PD-L1?
I'm not convinced it is. Okay. Numerically, to your point, if you look at the response rates in individual separate trials, anti-PD-1 has given numerically high response rate, but I cannot have any concrete evidence to say one is better than the other in urothelial cancer.
You think there's a difference?
Based on randomized trial.
I think based upon kind of mechanism plus the data, there may be a little bit of a trend for increased efficacy with PD-1 and a little bit of a trend for increased safety with PD-L1, but in the real world, I don't know if that's really different.
Really difference, okay. Another question here. It's so good to have the iPad. I really like this. When is overall safety data expected from Checkmate 274?
Overall safety?
No, survival.
Survival, yeah, great question. I wish I knew the answer. It's a great question. Whoever asked, I don't know. We keep asking, and obviously this is an event-driven endpoint, so the answer we're getting is that they do not have enough events, which actually, if you think about it, it's a good thing. People live longer. Right.
So yeah, that's right. So there's a presentation on that trial tomorrow. I didn't know what was it was going to be OS or not. I guess it's not if you know.
I don't know. We'll have to wait for the data. So tomorrow, Checkmate 274 updates. So I will try to run through quickly to allow time for Scott as well. And I will talk about metastatic urothelial carcinoma from bladder or upper tract or urethra. And I think in my mind, after many attempts to replace platinum-based chemotherapy, in my practice, when I go back to Seattle on actually Tuesday, it's a working day, then my patient in clinic who comes with metastatic urothelial cancer, and if they're fit to get platinum-based chemotherapy, they will get induction platinum-based chemotherapy. Ideally with cisplatin, if I can, that's my preferred option. My plan B is carboplatin, and we definitely have data for quite some time now looking at that question. The trial I'm showing you here is an old trial looking at GEM-CIS compared to the older classical conventional MVAC. That MVAC is not used anymore. It's not the dose-dense MVAC. Dr. Tagawa mentioned that Dr. Sternberg did the trial with the dose-dense MVAC versus the classic MVAC, and dose-dense MVAC looks a trend towards longer survival and easier to give. So the big question is GEM-CIS or dose-dense MVAC in metastatic disease? I think most of us use GEM-CIS, right, Scott? Metastatic urothelial cancer. And the question, of course, is, many patients may not be able to tolerate cisplatin, and that's a common problem. These are more senior patients, significant neuropathy, hearing loss, heart failure, performance status, kidney function, all of those issues. And the question here is, which parameters do you consider when you determine a patient's eligible for, I would say here the question is platinum. Of course, when we say platinum, is cis and carbo. So let's answer the question here. Which parameters do you take into account when you decide, let's say, cisplatin or carboplatin in the first-line setting of advanced urothelial cancer? Performance status, creatinine clearance, neuropathy, heart failure, all of the above, some of the above. Music is on. Scott, I'll make sure I'll give you a few minutes at the end.
One slide a second.
So 3/4 of you said all of the above, 1/4 some of the above. Awesome. So how do we define cisplatin eligibility? Is based on the Galsky criteria. This was published in JCO 2011, and look at all the things that were in the previous slide. More recently, Dr. Gupta from Cleveland Clinic is running an effort to define platinum ineligible patients, meaning those who cannot receive even carboplatin. ECOG PS of 3, creatinine clearance below 30, neuropathy grade 2 or higher, heart failure, and ECOG PS 2 plus creatinine clearance below 30, and heart failure class 3 or higher, so symptomatic heart failure. These are the criteria that if any patient has any of those may not feel comfortable giving carboplatin. And this is, of course, the manuscript under development. This is a consensus based on 60 medical oncologists who answer these questions. There have been many trials looking at the question, how can we improve upon platinum-based chemotherapy? And many of those trials have resulted with not changing practice. But the one trial that actually changed practice is the Javelin Bladder 100 trial. We have talked about that before in the last about 3 years. This is a trial in the switch maintenance setting. This is a trial for patients who have achieved response or stable disease in first-line metastatic urothelial cancer. So those with progression did not go on the study. And this is avelumab, anti-PD-L1 plus best supportive care versus best supportive care alone. Primary endpoint was overall survival. This was met. This was an update from ASCO GU last year. You see the median overall survival approaching 2 years from the time of starting avelumab maintenance. And there was also a significant prolongation, not only in overall survival, but also in progression-free survival. And this benefit appears to be across the board in different subsets of patients. Again, those little slide there, you see that the benefit seems to be consistent across the group, with different degrees of benefit. Patient-reported outcomes is important. Quality of life matters. We published this manuscript at European Urology a few months ago, and we saw that the OS and PFS benefit with avelumab maintenance came without significant detriment in quality of life. So these patients were able to maintain quality of life, which is important metric for them, and this is probably because you delay time to progression with symptomatic progression. And actually tomorrow we have 2 interesting posters. One of them is called Patriot 2. This is an observational study looking at real-world data in frontline setting of advanced urothelial cancer. There are multiple institutions participating. I will welcome you to our poster. I think it's in the bottom of the slide. So come over, we'll talk about the data in detail. And Dr. Bakaludi, who is sitting here in the front table, is presenting some real-world data with avelumab maintenance from 26 centers in the US and Europe. So exciting to see this data in the real-world practice with maintenance avelumab, how these patients fare outside clinical trials. EV302 is a very important phase 3 trial looking at pembro plus EV combination versus chemotherapy. That's one of the biggest trials to look for. It will probably result in the next year or so. Pembro EV is a very promising combination versus chemotherapy. A lot will be discussed about checkpoint inhibitors in platinum refractory disease. The take-home point is, if you have a patient who get maintenance immunotherapy, they get avelumab. If they have progression on chemotherapy and they never go to maintenance, the checkpoint inhibitor of choice is pembrolizumab. And I know Dr. Zhao and me share many patients who have been in that scenario, and pembro is one of the checkpoint inhibitors with level 1 evidence in platinum refractory immunotherapy naive disease. The response rates remain low. That's why we do combination trials. And again, tomorrow we're going to present data from cohort 3 of Trophy trial, and Dr. Tagawa is part of that. So Trophy trial, cohort 3, sacituzumab plus pembrolizumab combination. Very quickly, erdafitinib is an FGFR inhibitor. This has FDA approval accelerated for patients with FGFR2 or 3 activated mutation or fusion, and this is given at 8 milligrams once a day based on the phase 2 trial published in the New England Journal of Medicine by Dr. Loriot and colleagues, 2019. And this is, again, single-arm study, erdafitinib FGFR inhibitor, response rates between 30 and 40% for FGFR2 or 3 mutation or fusion, not amplification. So it's very important to look at the NGS panel and check, for those FGFR2 or 3 mutations or fusions in those patients. Of course, you see on the right part of the slide different subsets of patients. Toxicity can be relevant, and of course, we select the patients based on the biomarker. At the same time, we have to send the patients to an ophthalmologist at baseline. This drug requires eye exams on a monthly basis initially, and other side effects, stomatitis, fatigue, ponatremia, hand-foot syndrome, visual changes, so on and so forth. There's of course, a phase 3 trial ongoing, the Thor trial, and we're going to see whether the phase 2 data pan out in the phase 3 study. And that's a phase 3 trial, erdafitinib compared to pembrolizumab, second-line platinum refractory, or erdafitinib versus taxane or vinfluin for those with prior immunotherapy. Very interesting data with antibody-drug conjugates. Anti-HER2 is something that comes up in the pipeline. The system of vedotin is a compound made in China and now is actually licensed by a US company. combination between anti-HER2 ADC plus checkpoint inhibition, very promising data. So stay tuned. I think anti-HER2 are very, very promising agents in the future. And here you have a slide looking at the antibody drug conjugate against HER2 and checkpoint inhibition, a slide by Dr. Galsky from ASCO. And definitely, I want to make sure I give the stage to Dr. Tagawa to talk about drug conjugates. But these are the 3 drugs that were approved in the last few years. Erdafitinib, FGFR inhibition, as I mentioned, NGS testing is important at the time of diagnosis of metastatic disease. Look at FGFR2 or 3 mutation or fusion. And of course, Scott will talk about the 2 antibody drug conjugates and enfortumab sacituzumab. Before we go that, we have one question. 69-year-old lady underwent radical cystectomy for BCG responsive T1 tumor. Assessment after surgery, GFR more than 60 ml per minute, ECOG PS 0, no heart failure, no neuropathy, no hearing loss. Pathologic stage T2N1 has a positive lymph node at the time of radical cystectomy. Which adjuvant therapy option would you go for? Again, this is a patient who looks fit for cisplatin, right? And you have the option of giving adjuvant atezo, gem-cis, gem-carbo, or adjuvant pembro. And again, this is bladder cancer, not upper tract. Please vote. And Scott is doing his stretching because he's coming to the stage. Okay. So we have here adjuvant gem-cis, about 80% of people. And I think adjuvant gem-cis is the right answer. What do you think, Scott and Sam? Cisplatin fit patient.
Agree.
Yeah. Agree? Yep. Okay, let's move on. One more question. 72-year-old gentleman with metastatic urothelial cancer, lymph node and lac metastasis, GFR 41 ml per minute, so not great for cisplatin with low GFR. ECOG PS1, got carbo-gem, and had a nice partial response after 6 cycles. Which maintenance therapy option would you give based on level 1 evidence? Atezo, avelumab, nivo, pembro. I'm reminding you, this is based on the Javelin Bladder 100 trial that I just showed you. Please vote. Let's see what we have. Avelumab, there you go. So avelumab was a checkpoint inhibitor tested in the Javelin Bladder 100 trial and has level 1 evidence in the switch maintenance setting. Glad to see that there was change between pre and post. One more. I want to see Scott on the microphone. This patient started maintenance immunotherapy with avelumab, given at 800 milligrams every 2 weeks, the avelumab standard FDA-approved dose. Now is about 4 months on maintenance avelumab, and the patient has progression. Which of the following is not a reasonable therapy option? Another checkpoint inhibitor, the patient just had progression on avelumab, anti-PD-1, clinical trial, enfortumab, erdafitinib, sacituzumab. Which one is not a good option in this patient? Please vote. Okay, I think we all agree. 9 out of 10 said no checkpoint inhibition. And I agree, I think that option, we need more data about ICI challenge. I think we have other options, and all the other 4 options are reasonable. So I agree here that I would go with one of the other options. And this is how I treat metastatic urothelial cancer in clinic, platinum-based chemo followed maintenance avelumab. Cisplatin is preferred, and of course we talk about pembro as an option second line. Erdafitinib, FGFR2 activating or FGFR3 activating mutation or fusion, and Scott will talk about the enfortumab vedotin and sacituzumab govitecan, the 2 antibody drug conjugates, and of course clinical trials are always great options. I will leave this slide for you to read, and I will invite Scott to take over. Thank you.
Thank you, Petros. Now you all know how fast he can talk. All right, I can get through this. So we'll leave at least some time for questions. I won't speak probably as fast as Petros because I can't. So ADCs, I'm not going to get into this in great detail, but there are several different factors. And just suffice to say, what happens in the body is different, largely based upon these different factors. I'm going to leave it like that. And I'm going to talk about a couple differences as we get into specific examples. So enfortumab vedotin that will likely call EV for the rest of this talk, has a target of Nectin-4, which importantly for this particular talk is overexpressed in the vast majority of urothelial carcinomas. It is linked to MMAE, which is a potent antimicrotubule drug, via a protease cleavable linker, so fairly tight linker that's designed to release intracellularly. Following phase 1 study, it looked quite interesting. Actually, 2 phase 1s in the same company looked interesting, and this drug is the one that went forward. This phase 2 study, you can see these kind of split off in the schema, not randomized, just 2 different parallel cohorts, one with prior platinum as well as immunotherapy, and one that was cisplatin ineligible with prior immunotherapy alone. I'll walk you through each one of these. This is the single agent dosing, 1.25 milligrams per kilograms, 3 weeks on, 1 week off. Each of these were single arm overall response rate endpoints, and we were all very impressed. This replicated the phase 1 data. And put things into context, we're used to cytotoxics in this post-platinum setting of 10%, maybe getting up to 15%. So this was quite impressive and actually led to the initial accelerated approval of this drug. In the post-IO cisplatin unfit setting, very similar data. This led to actually a broader approval, accelerated, of 1 prior line of therapy. That was backed up by the confirmatory study, EV301, which took the same drug, same schedule, 3 weeks on, 1 week off, versus limited dealer's choice, basically taxanes in the United States or where vinflunine was available, vinflunine with the primary endpoint of overall survival. And you can see here, this made the New England Journal, 2 finger tests, an improvement in overall survival versus dealer's choice chemotherapy. And in the smaller bullet points at the bottom, the additional secondary endpoints for efficacy were also met: PFS, response rate, disease control. You don't have to go through this forest plot overall, but overall, each individual subset, there's some very small ones, but every individual subset benefited from EV versus dealer's choice chemotherapy. Adverse events, you can look at the specific table I have on the right, called out some of the key factors. So lumping across trials, I would say that rash occurs in around half, usually grade 1 or grade 2, but we do see grade 3 and sometimes as much as Stevens-Johnson. So that's not a common event, but we need to be aware of that. Most of the time, supportive care is all that we really need. But when it does get higher intensity, then holding drug, potentially coming in with a dose reduction after improvement, and sometimes an improvement requires, or we actually know if the steroids are needed, but when it is higher grade, sometimes we instinctively give corticosteroids. Whether it improves things faster, we don't really know, but sometimes these can be scary, just the way that it looks. This is an AE that might happen early in the treatment, cycles 1 and cycles 2, although it can happen later. Neuropathy is not surprisingly, because of the MMAE payload, about half. Again, the vast majority are grade 1 or grade 2. Grade 2 can have an impact on quality of life. If you look up CTCAE, sensory, grade 2 adverse events, one of the definitions is inability to use a phone. I think I don't actually know, maybe the old rotary phones, but still, we use our phones all the time. Hyperglycemia was something that was identified during phase 1. There were a couple of deaths, so it is important. We do know that I have the control rates, and despite the control taxanes getting corticosteroids, it was still higher. So this is something that, importantly, if you look at the label, we want to assess with an A1C. I think that this drug can be used in diabetics. We just want to make sure we control their glucose first. EV103 is a multi-different cohort combination study, doublets and triplets. I'm really going to talk about one specific doublet that, I can't remember if you showed the data or not, but the Pembro EV combination. So this is first-line metastatic, cisplatin unfit. very impressive waterfall, but what I think is even more impressive is the spider plot. And you can see, number one, there was a high response rate, and those responses were durable. Median duration of response greater than 2 years. This is cisplatin unfit. Unmet need. Importantly, there did not look to be a significant increase in the adverse events. So there's our IRAs, like we'd expect with Pembro, didn't seem to be so much higher. Was there overlapping toxicity with EV? Not clearly. I will tell you, as someone who's used this regimen, both of them have skin toxicity, not all the time, but the interpretation, what we might do with that about the skin toxicity may be a little bit different. So this is, I will more often turn to my dermatology colleagues for help, and often a biopsy. Is it immune related, or is this deposition? I didn't say this before, Nectin-4 is in the skin. At the end of that schema was cohort K, randomized EV alone versus EV plus Pembro, not designed to be compared, just to look at the different components of the individual drugs. And I would say in a quick summary is this really replicated that very high overall response rate and really validated that EV alone, it almost always has this 40-something% response rate, and really validated in this frontline cisplatin unfit group. This combination has breakthrough designation, so because of cohort K, we might see accelerated approval in the United States, to be backed up by the EV302 study that Petros already showed in terms of the schema. There's a couple of different waterfall plots. This is the one that the asterisks are, those are, so the different colors are by PDL1. There's another one that looks at it by Nectin-4 expression, and those don't really matter. Almost everyone has high Nectin-4 expression, but those are not biomarkers that are going to be predictive. Switching gears. TROP2 is an epithelial marker on a number of different epithelial tumor types, including urothelial carcinoma. What this shows is that across different urothelial subtypes, except for neuroendocrine small cell, which you can see at the middle of the bottom, high levels of TROP2 expression. Sacituzumab govitecan is a different type of an ADC. It's kind of anti-prototypical, if you will. So rather than having a really, really potent payload, one that you can't give it all systemically free, this is SN38, which is the main active metabolite of irinotecan, actually can be given systemically. Not that well, but easier than almost any other payload that's there. And this hydrolyzable linker is designed to release early. So it's designed to release intercellularly, but also into the stroma, so bystander effect. There was a phase 1 study, a number of different diseases. Early on, we recognized in 6 patients on this phase 1 trial, published by my colleague Boucher Faltis, who was home writing an R1. We were texting with him. We said, okay, you know what, this is interesting. Let's do an expansion. There was a basket trial that looked interesting, a cohort of urothelial, and that led to the Trophy User 1 study, similar, if you will, to kind of that EV103 study, multiple different cohorts, different patient populations, as well as combinations. I'm going to go over cohort 1, and then we'll come back to the other cohorts. So this cohort 1 is patients that had at least prior platinum chemotherapy, as well as immune checkpoint inhibition. What you'll see on that middle, kind of 1/3 down on the right, one patient did not have a prior immune checkpoint inhibitor. So if you are wondering why, because I get asked this, it's trivia if you ask me, but I guess it's asked all the time, why is there 113 in the paper and 112 in the label? That's why the FDA took that one out. But heavily pretreated, generally a 4th-line therapy, a lot of visceral disease. And analogous to the 201 EV study, single arm, overall response rates excluded a 15% kind of historical control, and this response rate led to the accelerated approval of this drug in this pretreated patient population. You can see here the swimmer plot and the spider plot, as well as a reasonably versus historical control, reasonable PFS and OS, although in a non-randomized setting, we don't know exactly how to interpret that. This type of a ADC has a different toxicity profile, which is nice if we're going to use them either together or sequentially. So across tumor types, and this is approved in triple-negative breast cancer and now ER-positive breast cancer. Neutropenia is the dose-limiting toxicity. You can see that in this urothelial population, about half, with grade 3-4 in about a third. Febrile neutropenia in about 10%, and this is despite growth factors that were allowed. Diarrhea in about 2/3. Usually low grade, and usually not throughout the entire cycle, because grade 2, that's up to 6 times loose stool compared to baseline. That some people don't want to leave the house, so even grade 2 can be life-changing. Luckily, this usually happens only for a few days per cycle, but it is helpful to know about these and get on top of this. So I make sure that prior to cycle 1, day 1, there is an anti-diarrheal at home. Trophy user 1, again, multiple cohorts. The first 3 are going to be updated tomorrow. So longer follow-up of cohort 1. Cohort 2 was initially preliminary presented several years ago by Dan Petrolak. Tomorrow morning, the 7 to 8 a.m. session, get up early, will be presented orally in the rapid abstract presentation. So I won't steal Dan's thunder, but that is specifically, at least at the time of entry, platinum ineligible, as Petros was saying before, not carbo eligible, and I'll let you see that update tomorrow. Cohort 3 is also going to be updated, but I will show you Dr. Grivas' presentation from last year. This data was a late breaking, and that data came in late breaking. So we're going to really see some updated data, and it will be different, just as a preliminary thing. You need to go find this poster. So an ADC IO combination, but rather than being frontline cisplatin unfit, this is post-platinum, so a different patient population. Post-platinum, they could have had more, but generally speaking, it was mostly second line. Fairly sick patients, rapid progression on platinum, mostly visceral metastasis, so it was a sickest patient population. Primary endpoints of response, actually it's not here, which you can see here. So based upon the pre-specified endpoint, this was a positive trial, and again is going to be updated. This is early, so we don't know about durability, but we are going to update the response rate as well as the follow-up. Interesting across different subsets. Again, when we do a combination, is there going to be any synergy in the bad way? Is there going to be more toxicity? I wouldn't say that is there officially maybe a little bit more diarrhea, but nothing that was kind of out of this world. About 10%, is this not on the slide? Not on the slide, sorry. The IRA is the next slide. So not so different than either one alone, but in my mind could diarrhea be a little bit different? What I was getting into, the IRAEs, not so different than we'd expect. About 10% required systemic corticosteroids. So SG has an accelerated label for patients with metastatic urothelial carcinoma, post-platinum, post-immune checkpoint inhibitor. That's accelerated based on a single-arm trial. The confirmatory trial, the TROPiCS-04 trial, SG versus limited dealer's choice, just analogous to the EV301 study. Fully accrued, we're just waiting for the data. Okay, question. LH is a 64-year-old female who is receiving enfortumab vedotin, aka EV, for metastatic urothelial carcinoma following disease progression on both cisplatin gemcitabine and maintenance of avelumab. After 3 cycles, she develops a mild but bothersome rash, which you determine is CTC AE grade 2. That means between 10 and 30% of body surface area. What is the most appropriate next step for LH's treatment? Observe the rash, continue EV. start high-dose oral steroids and permanently discontinue EV, start infliximab, start topical or low-dose oral steroids and temporarily hold EV until AE resolves, switch to atezo. Okay, so, the interesting thing is that what some recommendations say and what some clinical trials say are a little bit different, because on a clinical trial for grade 2, we could continue. But I'd say the key here for this grade 2 is symptomatic grade 2. So I would agree that some topical supportive care could include an H1 blocker, et cetera, in addition to topical. And low-dose systemic steroids would be a possibility. I probably would not go with systemic in this particular situation because we're talking about limited body surface area. Switching to SG, which were the most common high-grade adverse events associated with tacituzumab govitecan therapy in trophy user 1, we'll say cohort 1. A, neutropenia and diarrhea. B, neutropenia, hyperglycemia. C, rash and hyperglycemia. D, rash and peripheral neuropathy. Okay, most people got it correct the first time, and we made that a little bit better the second time. Exactly. So just to summarize, we currently have 2 approved ADCs for advanced urothelial carcinoma, 2 different targets. So part of the profiles of each one has to do with the target, but it also has to do with the linker and the payload. So EV, high response rate overall, fully approved. What we will look out for in about half, neuropathy and rash. Hyperglycemia, not the most common, but can be a problem. And then we have TROP2 targeting with SG, a different construct, neutropenia and diarrhea we will really watch out for. There is some nausea too, but usually that's reasonably managed. Importantly, which I didn't get into, we know that we can use these sequentially. It's still a little bit anecdotal, but we do know that in either direction, one can have efficacy after other. In the current era with SG approval after EV, that's more of the data, does not look so different in terms of response rates before or after EV. So I basically summarized, I'm just going to drop to the last bullet point. There are additional ADCs being investigated. HER2 was already mentioned. There is one, I only have 2 listed here because those are the 2 with FDA breakthrough designation. I'm not sure what's going on with the anti-EpCAM one as a potential another intravesical option for non-muscle invasive, but clearly this world of cell surface targeting actually across different diseases, but especially also in urothelial, so our patients have more options.
Fantastic.
Thank you.
Scott, one quick question for you. So someone is asking, what do you think about the role of ADCs will be going forward? You alluded in the last slide, remaining in the second line and beyond, or they're going to move in the earlier lines, first line or even neoadjuvant, adjuvant. And secondly, how would you approach deciding which ADC to give first and sequence?
So I believe that the data are strong and it's a label expansion. So I believe that EV plus Pembro is likely to move, at least in the United States, to the first line setting with accelerated approval in cisplatin unfit. I didn't get into the details of the EV302 study. There, it started and the control arm for most of it did not have maintenance. So, that's what they're, and I don't know, it's going to be mostly cis, mostly carbo, so we'll have to see there. But that being said, based upon the available data, I'm pretty confident it's going to get approval, and I'm probably going to use it for cisplatin unfit. Am I still going to use cisplatin sometimes? Maybe. I'll have to see what that data shows. So, we've had, back to MVAC, 2 different combination cisplatin trials that beat cisplatin alone, nothing ever really beat MVAC. That gemcis was a negative trial. It just happened to be around the same with less toxicity. But now maybe we're going to be able to beat platinum combination. So that I think will be a major shift if that actually happens. In terms of let's say kind of current on label, someone's had platinum, someone's had IO, EV, even erdafitinib or SG. How am I going to pick? So the easiest way to pick for an average person is one drug has randomized data, the other two do not yet. So on average, I would say go with the level and evidence and likely to use EV. That being said, if there is someone that starts off with a lot of peripheral neuropathy for whatever reason, or let's say bad diabetes, got worsening neuropathy with platinum, so it's both hyperglycemia as well as neuropathy, then I might choose SG or erdafitinib if they happen to have an activating mutation.
I agree totally. I think it's a matter of patient, comorbidities, side effect profile, level of evidence, to your point, efficacy, convenience, treatment burden, all those factors, like going back to your NMIBC discussion. So exciting. I think we have a couple of more polling questions. Is that right? So we can advance a slide and see what we get. Thank you, Scott. Yeah, I think we're probably near the end. Justin, anything else we need to cover, or we're all set? I get a green light, and I have a green button here. So thank you so much, Scott. Thank you so much, Sam, for wonderful presentations. Thank you so much, again, Beacon, sponsors for this event. We had a grant for Gilead, I think, supporting this CME, and of course, to see concepts. It's just amazing to see what is happening in this disease. The last 90 minutes, we covered, I think, the entire spectrum. So hopefully we'll have even more to talk about in the next meeting. Thanks to the audience for being here. Thanks to the virtual audience. Enjoy ASCO GU. Good night.